Before disease takes hold, a healthy human artery operates with pristine structural integrity. The vessel wall is lined with an intact endothelial layer, sitting securely above a responsive band of smooth muscle. This baseline endothelial layer is highly active. It maintains vascular tone by signaling the surrounding smooth muscle to relax, and it forms a frictionless, non-stick surface that actively prevents circulating blood from clotting. Ischemic heart disease represents the functional endpoint of a precise four-stage inflammatory and structural breakdown of this specific vascular wall. Plaque formation is a biological process of active tissue destruction, occurring within the vessel wall itself, rather than simply settling on top of the tissue like mineral deposits in a pipe. The cascade is initiated by chronic systemic stressors. Mechanical stress from high blood pressure, circulating chemical toxins from smoking, and metabolic overload from high circulating glucose all attack the endothelial lining. These continuous attacks initiate a microscopic, decades-long biological chain reaction that ultimately destroys the vessel wall, leading directly to acute myocardial ischemia. To understand the mechanism of a fatal heart attack, we must ignore the final clot. The true pathogenesis requires examining the exact cellular dysfunction that began decades prior. The disease originates precisely at the endothelial cell membrane, the thin biological barrier separating the bloodstream from the vessel wall. Chronic high glucose levels in the bloodstream lead to the formation of advanced glycation end products, or AGEs. AGEs are harmful compounds created when proteins or lipids become glycated as a result of exposure to sugars. This diagram illustrates stage 1. Circulating AGEs bind to RAGE receptors on the endothelium. This triggers an internal burst of reactive oxygen species, causing severe cellular damage. The ROS burst inhibits the eNOS enzyme, blocking nitric oxide production and scavenging any existing nitric oxide. The mechanical consequence of nitric oxide depletion is immediate. The underlying smooth muscle loses its primary chemical relaxation signal and locks into a rigid, constricted state. With its cellular signaling disrupted, the endothelium loses its non-stick properties. The loss of nitric oxide converts the tissue from a neutral, protective barrier into a pro-inflammatory environment, priming the artery for lipid invasion. The persistent pro-inflammatory state degrades the structural integrity of the endothelial barrier itself. The tight junctions holding the cells together begin to separate, creating microscopic physical leaks. LDL breaches the compromised barrier, embedding deeply into the intima. Trapped inside, it interacts with ROS and oxidizes into ox-LDL. Flagged as a pathogen, monocytes infiltrate the tissue, differentiating into macrophages. These macrophages aggressively gorge on the ox-LDL, swelling into bloated, lipid-laden foam cells. These foam cells are biologically incapable of processing this massive lipid load. As they fail and begin to die, they actively secrete inflammatory cytokines, signaling proteins that regulate immune responses directly into the surrounding tissue. This localized cytokine release creates a devastating positive feedback loop. It chemically recruits thousands of additional immune cells to the site, converting a minor subendothelial leak into a permanent, expanding site of severe inflammation. The intense localized immune response forces a structural remodeling of the blood vessel wall, driven entirely by the accumulation of dying foam cells. As the foam cells undergo necrosis, they release platelet-derived growth factor, or PDGF. PDGF is a potent protein that strongly stimulates cellular division and growth. Smooth muscle cells migrate into the inflamed intima. They synthesize a tight matrix of collagen, attempting to wall off the infection with a fibrous cap. A thick cap indicates stability. However, persistent inflammation actively degrades the collagen, creating a thinned, vulnerable cap. This creates a dangerous internal structure. Beneath the cap lies a pressurized necrotic core, composed of dead foam cells and crystallized cholesterol, precariously sealed off from the high-pressure bloodstream above. The thinning of the fibrous cap is an active, ongoing process, driven directly by the continuous release of inflammatory cytokines and enzymes that began in the previous stages. The structural integrity of the fibrous cap determines the immediate risk of a heart attack, carrying more clinical weight than the plaque's total volume. Years of persistent, low-grade inflammation eventually push the fibrous cap to a mechanical tipping point, severely compromising its tensile strength. Ultimately, unable to withstand the continuous shear stress of the circulating blood, the severely thinned cap violently ruptures. This structural failure instantly exposes the highly thrombogenic necrotic core, alongside subendothelial collagen fibers, directly to the open bloodstream. As illustrated in stage 4, the hematological reaction is instantaneous. Circulating platelets bind to the exposed collagen and switch to an activated state. They immediately release chemical mediators, specifically TXA2 and ADP, which heavily promote further platelet activation and massive local cellular recruitment. Thromboxane A2 also binds to severe, localized vasoconstriction that violently narrows the remaining physical diameter of the vessel lumen. Thousands of platelets aggregate at the rupture site into a dense primary plug. This kicks off the secondary coagulation cascade. Fibrinogen converts into insoluble fibrin strands, cementing the clot. This rapidly expanding mass leads to total vessel occlusion and ischemia. Natural anticoagulants are completely insufficient. This rapid failure of hemodynamic homeostasis creates an absolute blockage. Oxygen supply drops to zero, and the muscle begins to die, resulting in acute myocardial ischemia. The pathogenesis of atherothrombosis operates as a single, unbroken chronological chain spanning across decades of a patient's life. It initiates in stage 1, where chronic metabolic stress severely damages the delicate endothelium, providing the crucial opening for disease. In stage 2, the infiltration and subsequent oxidation of lipid particles drive a highly destructive immune response deep inside the intimal layer. Stage 3 brings desperate cellular remodeling. Smooth muscle cells construct a temporary, vulnerable fibrous cap over the rapidly expanding necrotic core. And stage 4 is the inevitable structural failure of that cap. Its rupture triggers the rapid, fatal ischemic cascade. In modern clinical medicine, emergency room interventions focus exclusively on resolving that final stage 4 clot to forcefully restore immediate blood flow to dying heart tissue. But true long-term prevention demands intercepting this biological sequence at stages 1 and 2. It requires aggressively managing the systemic stressors that disrupt enos and drive lipid invasion, intervening at the cellular level decades before a vulnerable fibrous cap ever forms.